Welcome, good morning, good afternoon. We are so pleased to have you here with us today. My name is Ashley Zlatinov, and I look after public policy for Google Health. Today, we have experts joining from a variety of federal, state, and local governments, and also nonprofits, academia, and more. We really hope that this session will be informative and interactive, a chance to hear from our partners and also from our team on data resources to inform COVID vaccination interventions, while also providing an opportunity to ask questions and build connections. So first, for a few housekeeping logistics, the session is going to be recorded and posted on YouTube. We'll plan to spend about 30 minutes of presentations, followed by an open Q&A. Given we're all on Google Meet, we ask you to mute yourself when you're not talking and to turn your video on when you're speaking if you're comfortable. You may use the hand raise function, which is the little hand in the lower right-hand corner if you have a question. And you're also welcome to add questions using the Q&A option. To do so, you can click on the triangle button on the side of your screen, select Q&A, enter your questions like post, or just put your question in the chat and we'll get to those as well. We'll cover questions at the end, and I'll go ahead and get started. Feel free to add them as we go. So we all recognize the devastating impacts of the continued coronavirus pandemic. With vaccinations available in many places around the world, efforts are being made to help ensure equitable access to vaccines and also access to timely information. We're really proud to have the opportunity to partner with several leading organizations, including Ariadne Labs, Boston University, and Boston Children's Hospital, on tools to inform research and public health decision-making. Today, you'll hear more about the public health and policy landscape from Dr. Karen Smith and about new tools from our partners, Dr. Weintraub, Faculty Director of the Global Health Delivery Project at Harvard University, and Director of Better Evidence at Ariadne Labs, and also Dr. Greg Wallenius, Professor of Environmental Health at Boston University and School of Public Health and Director of Boston University's Program on Climate and Health. Google's Mansi Kansal and Tomer Shekel will also share about the tools we've been working on jointly. Work in this space is a truly collaborative effort, and with tremendous thanks to the many who have helped support and move this work forward. So first, I'll hand this over to Dr. Karen Smith, infectious disease and public health physician and former director of the California Department of Public Health and state public health officer, who's going to give us an overview of the landscape and help set the stage from her decades of public health experience. Karen, over to you.
Thank you, Ashley. Good morning and good afternoon, everyone. Thanks for joining us today. A lot has changed in the past 2 months or so. As you all know, Delta variant is now the dominant strain across the United States. The variant has markedly increased transmissibility, and there is data to suggest that it might also cause more serious disease. We also now know that the fully vaccinated can become infected with Delta, although at a much lower rate than unvaccinated people, and the vaccinated folks clear the virus much more quickly. Both the fact that they become infected at a lower rate and clear more quickly means that people who are fully vaccinated are less likely to transmit the disease than those who are unvaccinated. Schools are opening, I think, across the country, and we're already seeing significant challenges with the incredibly important work of keeping kids in-person, face-to-face school. We've seen school closures because of significant outbreaks within school children, which carries the risk then of more children taking COVID back to their homes and the vulnerable people who may live with them. Young children, as you know, are not yet eligible for vaccination rates, and unfortunately, rates for kids 12 to 18 is actually fairly low across the country, although that it is increasing slowly. And there are, unfortunately, increasing numbers of children being hospitalized for severe COVID disease, though thankfully there have been few deaths so far. And on the vaccine front, Pfizer now has full approval from the FDA for use in individuals 16 years and older, and Moderna will likely receive similar approval in the coming weeks. And studies are ongoing for vaccination in kids younger than 12, and they are promising for both safety and efficacy. It's not entirely clear when they'll be finished, probably by the end of the year. The CDC recently recommended a third vaccine dose for people who are moderately or severely immunocompromised, and booster shots for other people are under discussion. The bottom line is that even in the face of Delta, with this incredibly rapid transmission, the current vaccines remain extremely effective in protecting against serious illness, hospitalization, death, and symptomatic disease in fully vaccinated people. Vaccine requires by far, vaccine remains the best and maybe the only way for us really to get out of this pandemic. Overall, US vaccine rates are pretty good, with almost 74% of adults 18 and older having at least one dose. But only half of the population is fully vaccinated, and there are significant disparities in vaccination rates. People with disabilities, those who live in rural and frontier areas, unhoused people, and communities of color are among the populations that are both at high risk of disease and have much lower vaccination rates. And there's an entire spectrum of vaccine confidence and hesitancy in the US. Most people who wanted to get vaccinated have done so, but there are also those who may have been really passive about vaccination, including those who just aren't worried about contracting COVID, or those who are too busy to get around to being vaccinated. There are folks who think that because they had previous infection, they're therefore immune. And those who would likely get vaccinated, but they're subject to social pressure not to be vaccinated. And then there are many people who are potentially interested in becoming vaccinated. Some of these folks have done extensive online searching. They're reviewing health education materials, following social media. They're not opposed to all vaccinations, and in fact may well have been vaccinated in the past for other diseases, and might very well be willing to take the vaccine in the future if their concerns are addressed. Now, across the country, public health, healthcare providers, and partners are working diligently to try to increase vaccination rates, especially in these more vulnerable and hesitant communities. And a variety of strategies are being used. The recently implemented vaccine requirements for work and popular leisure activities have been shown to be effective with some populations, particularly the younger populations. Pfizer's full approval for people 16 years and up may actually help convince some who've been waiting on the sidelines because they weren't really trustful of this emergency use authorization. But now that there's full authorization, they may come around. There are repeated surveys in a lot of populations, understanding the public messaging campaigns and expressed concerns and addressing those concerns. Especially powerful is the use of trusted messengers with clear messaging that addresses the specific concerns of their communities. And ensuring real access to disease is easy access to vaccine, and not just geographic location, but time and language spoken, et cetera, is going to be key. Today, we're going to talk about two new tools, Vaccine Search Insights and the Vaccine Equity Planner. We think these tools will be complementary to the existing efforts across the country to increase vaccination rates. So without further ado, I'm going to hand this off to Dr. Weintraub.
So many thanks, Karen. That was just tremendous remarks to open us up. I wanted to start with a moment of gratitude. Next slide, please. So in order to get to today, this has very much been an interdisciplinary collaborative effort amongst everyone on the screen and others to think through how do we leverage public data sets to help us mitigate the uncertainty. And as a physician and a vaccinator, I see at each phase of this pandemic, our providers, our health system leaders are facing a new set of questions. And we're hoping this tool, as well as others that you'll hear about today, will help you, in a sense, augment your decision-making and your planning ahead. Next slide, please. So, one of the questions we're asking at this stage is how can we reach the unvulnerable, including the unvaccinated? And to be clear, many of the unvaccinated are telling us they would prefer to get vaccinated at their physician's office. They would prefer their child to be vaccinated by their pediatrician. They would prefer to receive their second dose or their booster shot, for example, within their physician's office. So how do we ensure there's supply available and the vaccine is always on the menu in the midst of outpatient care? Next slide, please. A second unanswered question for local leaders is, which sites do I need to mitigate vaccine deserts? And I'll talk us through how we define vaccine deserts, but to remind ourselves that there's still a point in time where we're asking individuals, family members to come back for a second dose dose, to plan for their booster dose, to plan for their children and adolescents. And the accessibility of the sites need to be improved and upgraded in the days ahead. I'm going to pass the baton to my colleague Manzi to talk about a subset of the data that we use for the Vaccine Equity Planner.
Thanks, Dr. Weintraub. Next slide, please. So once again, thanks, Dr. Weintraub. So I wanted to talk a little bit more about how we identify vaccine deserts and Google's access to vaccination sites data set. To identify vaccine deserts or regions where it would take 15 or more minutes to reach the closest vaccine location, we first compute the area around a vaccine location that can be reached within those travel times. We call these catchment areas. So as you see the screenshot to the right, the little blue plus signs that you see are proxies for vaccine locations. The green and yellow regions are those from which the vaccine site can be reached within 15 or 30 minutes. And then the regions in red become the vaccine deserts, or where it takes more than that time to reach the vaccine locations. Just to call out that this is an example, does not represent real data, but a proxy. It is important to understand how long it would take to get to a vaccine location, not just based on pure distance, because traffic, road layout, etc., many factors play a role. We use the same infrastructure that powers navigation on Google Maps to calculate the travel times. Note that we don't use any user data for these computations. We compute these metrics at small geocells, which allows us to provide an accurate map of accessibility of vaccine locations. And we compute this not just for driving, but also walking and public transportation. Not everyone owns a car or can get to a vaccine location by driving. It's also important to understand how accessible the locations are for those relying on transit. We refresh the data weekly to ensure we capture the latest vaccine locations as new sites open and existing locations close. Google sources the vaccine sites from authoritative sources such as Vaccine Finder, government agencies, and directly from retailers and providers. In addition to powering the Vaccine Equity Planner with this data, we also made the data set publicly available to allow public health organizations and researchers to use this data and integrate into existing tools and data sets. And now I'll hand it over back to Dr. Weintraub to explain how you can use the Vaccine Equity Planner to identify vaccine deserts and look for potential sites within those deserts.
Many thanks, Monk. Next slide, please. So if you go to vaccineplanner.org, please play around and demo the site as we're discussing today. It's eager for your suggestion for upgrades today. So the first step here is you can actually map the vaccine deserts in your area by your state or by your zip code. You can then display the counties by the Center for Disease Control Social Vulnerability Index. You can shade the counties by the number of people who intend to be vaccinated but are not yet vaccinated. And then here's a key point. You can define a vaccine desert, as Manzi mentioned, by either 15 or 30 minutes of driving, 15 or 30 minutes of walking, or 30 minutes on public transportation. And you'll see how the vaccine deserts change considering which choice you make. And then the second step here is you can display potential sites within those deserts. So think of these are current active providers, for example, who do not currently have supply of the vaccine. You can also look at places of worship or schools as you think about the rollout of the vaccine for children later this year. And in the bottom left-hand lower corner, you can download the data if you're trying to think about outreach or where to place your mobile ban for future phases of your vaccine rollout. Next slide, please. Here's just an example. This is in Alabama, where you can see the tan area, unfortunately, is a vaccine desert. And you can roll over and see, here is a site, the Clayton Family Health Center in Clayton, Alabama, that currently does not have supply that could be vaccinating and would mitigate the effects of that vaccine desert. Next slide, please. And alongside our friends at Google Maps, we were able to then integrate, and you can roll over the actual address, and Google Map pops up for the contact information of the site. Next slide, please. So this has been just a tremendous journey where we've been able to augment how state leaders are planning for their vaccine rollout. Here's a wonderful example from Mississippi. Jim Craig has been using the Vaccine Equity Planner in the midst of his press conferences. So he shows how the vaccine deserts are changing over time, and then thinks about the planning ahead for future sites, not only locations, but hours, and the importance of availability for the general population. Next slide, please. In addition, as Mansi mentioned, we've been updating the site every week since its launch, so you'll be able to see changes over time to the shape of the vaccine deserts. And for those of you planning interventions, it'll help you understand, did this new location and this new site mitigate the vaccine desert ahead? So here's an example. So from Oklahoma and Birmingham, and you can see the size of the desert, the tan area has decreased from 1 week to the next. Next slide, please. So just kind of a snapshot here of where we are with respect to the analysis of vaccine deserts as one arena to improve access. Unfortunately, we still know there's 68 million Americans who need one shot. 17 million are living in a rural vaccine desert, and about 50 million are living in an urban vaccine desert. So there's still work ahead for geographic access. And we also know that there are sites that we could begin distribution to. And as we think about the EUA for children later this fall, as well as the complexity of booster access, we have 815 primary healthcare centers and 800 federally qualified health centers that are not currently distributing the vaccine. In addition, if you're thinking about broadening your vaccine rollout, we've identified additional pharmacies, retail stores, and places of worship if you're planning outreach or mobile vans that are located on the map as well. Next slide, please. And as you can see, we've been updating the planner, so we have a new feature that helps you identify vaccine deserts by sites offering Pfizer vaccine, which is about 55% of the federal sites. So unfortunately, the size of the vaccine deserts are more significant for those looking for a Pfizer booster, for example, considering the full approval. And you'll also see upgrades to the site to enable you to find potential sites, including pediatric sites, and you can, in a sense, plan your rollout and prepare for 5 to 12-year-olds for later this fall. And I just want to kind of conclude in a kind of meta point here that we know from the evidence base that convenience improves confidence. And there's a direct relationship for having the vaccine available on the menu at all times. Every outpatient visit, every time you see your subspecialist, every time you're going to see a pediatrician, that family members can receive their second dose or their booster. And we also know, due to shelf stability and changes in FDA guidance regarding how long the Pfizer and the Moderna vaccines can be in the freezer, that there can be more vaccine available at more distant sites over time. So we're hoping this tool will help you as you begin planning for this next phase of the vaccine rollout, and eager for your input how we can upgrade the site for your purposes ahead. Thanks so much.
Hi, everyone. Next slide. So I'm Tomer, and let's talk about vaccination search insights. So building vaccine confidence and increasing vaccine uptake requires understanding of what are the barriers to the vaccination people are facing, what's their concerns, what's their motivators. We already spoke about access barriers. If we understand the spatial and temporal distribution of those concerns, the information they're seeking, maybe the motivators, it can help with more granular targeting or improved design of interventions to increase vaccine uptake. Over time, it can also be used for evaluating the impact of those interventions, what works better than others. Next slide. So Google search is where many people start their journey when they're trying to learn something about the vaccine or to understand maybe where to get vaccinated. They search for vaccination sites near them, maybe the information about the recent FDA approval for the Pfizer vaccine, or the Delta breakthrough cases and how likely that is. Now, if we take all those millions of search queries that are being sent every week and try to classify the intent behind them, then aggregate them, we can generate population-level trends that indicate what are the information needs, what are the concerns and interests regarding the COVID-19 vaccine by the different population. Next slide. Now, these kind of trends are really meant to augment existing data sources, addressing important gaps in the current sources. So today, usually the data sources are mostly surveys and social media. Now, surveys are usually resource intense, both from funding point of view and analysis point of view, which usually leads, among other causes, to conducting them in a low spatial granularity and usually low temporal granularity. So maybe once a month, maybe the state level, maybe large metro, maybe national level. And lastly, both surveys and social media suffer from known biases, like the selection bias on social media to be, the voices that are heard are not necessarily the voices of that represent really the crowd or of the overall population. Now, one click. With vaccination search insights, we often search trends related to COVID-19 vaccination that are trying to address some of those gaps. First, it's publicly available at no cost. We are refreshing it every week. We provide at the county all the way to the zip code level in larger counties. Now, it's also an independent data source, which is relatively less biased because something that a search is something that a person does with his computer. It's not something that it makes publicly on social media. And even the biases that it does have, it's quite different and dependent than the biases you'd see in other sources. And lastly, it's all aggregated and anonymized to make sure that we protect users' privacy and with no privacy impact for any of our users. Next slide. So let me walk you through our dashboard and the data that we're producing. So first, you can see here a map view of our data. You can see how interest in the information about COVID-19 vaccine change across different counties in the US. And you'll be also be able to go deep dive into larger counties and see the similar patterns in at the zip code level. The trend that we offer represent aggregated, anonymized relative interest, meaning the relative popularity of a given topic in search. At the moment, we offer trends on 3 categories. One is general COVID-19 vaccination searches, which is kind of a parent category. It indicates general interest in COVID-19 vaccination. Then we have 2 subcategories that are more specific. One we call vaccination intent. We include searches that indicate intent to get vaccinated. Am I eligible to get vaccinated? Where do I get vaccinated? Is vaccination available in my region? And safety and side effects, which is a broad category that covering searches related to safety and the side effects of the vaccine. Now, realize those are still relatively high level when it comes to the topics, and we are exploring how we can provide more details and context to what are people searching within those categories. Next slide. Now, in this slide, you can see our time series charts that allow you to see how interest in different regions change over time. Those charts offer a comparison view where you can see the US average compared to all the states, or maybe the state average compared to its counties, and similar county compared to its zip codes. And those kind of charts can help evaluating the impact of a specific intervention or perhaps an event like a vaccination incentive program done by different states, or maybe the Delta variant spread and the hotspots that are now available, or maybe it's the FDA approval. And how does that change people's interest in the topic of vaccination and what kind of things are they searching about? Next slide. So let's take a look at a particular example. So Michigan introduced a lottery that offered cash prizes to people who get vaccinated during July. In the graph on the left, you see that the vaccination intent category, the map on the left is really showing the vaccination intent category. That is the searches that has to do with specific people trying to figure out how to get vaccinated. You will notice that there's those dark areas around Michigan that indicate very high vaccination intent during this week. So it seems that the lottery did lead to an increase in people vaccination intent, at least as seen by search. On the right, you'll see the time series chart for that state, the state of Ohio, for the state of Michigan, and how it changes between the different counties. Though the orange line is the state and the gray lines are the different counties. You can see that the increase in vaccination intent is not uniform across all the counties. In fact, there's up to 4x difference between the county that had the biggest increase versus the one that had the smallest increase in vaccination intent. Next slide. In a similar way, we can dive one level deeper in the zip codes. You can see in the map and the time series for both Oakland and Wayne counties in Michigan. Those are the 2 most populous counties there. You can see a similar pattern like in the counties while all zip code vaccination intent spiked due to the lottery, there is still a large variance between the different zip codes. It can be up to 5x between the highest and the lowest increase in Wayne County among zip codes. The reason for the differences might be already high vaccination rate in some of the zip codes, maybe deeply rooted distrust in government in others, or perhaps that is some kind of incentive that doesn't resonate with certain populations. This is a good example of how our data can offer an independent, timely, and granular answer to question like which counties or zip codes were the most receptive to the campaign. How do those patterns align with the target population of the campaign? Now, a critical question that remains is whether the increased interest, as seen by search, actually translate to actual shots. And if not, why not? Is it an access problem? Is it that the population is already highly vaccinated? Or that it's concerns regarding the safety of the vaccine in those communities? Our data alone cannot answer those questions. For that, we need to integrate the data with other data sources, like the vaccine just before, or vaccination rates, surveys, and other sources. Our colleagues from Boston University explored some of those questions and will present just in a second some of the results. Next slide. Lastly, I wanted to show that in a similar way, just like we've seen right now from Michigan, you can view each state-wide incentive program in our data. Here are just a few examples from across the country. Now, let me pass the torch to our collaborator, Greg Relenius from Boston University, that is leading work to trying to connect search trend to actual vaccination rates and vaccine shots that can confirm and help understand how to use this data.
Great, thank you, Tomer. Next slide, please. So I just want to highlight and give thanks to the large team that's had the opportunity to work on this, including our partners at Google, as well as within Boston University and to the University of Washington. So thank you all for the team effort. Next slide, please. So the key question we were looking at, building on what Tomer just said, is that there's obviously this time trend in the Vaccine Search Insight Index. We'll call it the VSI index. And remember, this is anonymized and in such a way as to aggregate and protect user privacy. So we're see the time trends in this search patterns indicating vaccine interest. And we see that that peaked in April and May, and then decreased into the summer, and now has increased again. And what you see on the lower graph is the time tracings for the percent of the population that's vaccinated. And so this really led to a couple questions around the relationship between search activity as captured by the VSI index and vaccination interest and intent. Next slide, please. So the first thing we did was really to ask whether does search interest reflected early in the pandemic or early in the availability of the vaccine, and we chose March as the time period of interest here. And does that predict the percent of the population that receives at least one vaccine dose at a later time? So we chose 3 months later. So this is searches in March and their relationship with vaccination status in May. And what you can see is that at the state level, there's this really nice correlation between those states where people were searching more for vaccines in March had achieved higher rates of vaccination in May, with a correlation of 0.75. And this was actually similar at different, if we chose April instead of March, and if we chose longer, slightly longer or shorter timeframes to look at. And it was also a similar relationship looking at counties. So counties that searched more early on in the spring of this year achieved a higher, tended to achieve a higher rate of vaccination status. Next slide, please. So then we wanted to ask a second question, which is, so that's sort of the where is their vaccine interest, and how does that manifest into vaccination rates sort of 3 months later? A different question is, how does search activity today or this week translate or correlate with interest in getting the vaccine in the next, say, 0 to 3 weeks? So that's what you see here is in the blue line, you have the state specific and then the average across those states for Google search index. And in the red line, you have the again, by state and average across the percent of the people with at least one dose of the vaccine. And you can sort of by eyeball test, there seems to be some similarity in the temporal trend. So we wanted to then, try to measure that. Next slide, please. So what you can see here is this is from a model that is trying to say, okay, for every sort of standard change, we chose a 10 unit change in the VSI index. How many more people does that translate to that got a first vaccination? And so you can see that in mid-March, for every 10 unit increase in the search index, an additional approximately 8 people per 1,000 received a vaccine. But this number is different across time. So next slide, please. So you can see that across time, in January, when there was some interest but very little vaccine available, there was a relationship. But then towards April and May, when there was still a lot of interest and increasing supply and increasing guidelines, for expanding population, the relationship between search and vaccines was actually quite a bit stronger. And as we have an increasing number of people that are vaccinated, or the flip side, shrinking population left unvaccinated, then the relationship has gotten smaller again. Importantly, this varies not just by time, but by states. If we look at this in a state-specific way, in some states, the signal is much stronger than in other states. Next slide, please. So the final question we were trying to address is whether we can use the search index based on these relationships we've seen. Can we use the search index to help public health officials identify populations that may be particularly receptive to new vaccine efforts or campaigns? And so what you see in the top left figure there is each county, this is in the state of Texas, and is color-coded according to tertiles of their search activity. And on the right side, those same counties are coded according to the percent vaccinated, again in thirds. And then in the bottom graph, what you see there is now we've looked at the intersection of where are there either high or low vaccination rates, and on the other axis, where are there high or low search interest. And so you can see is that there's actually quite a bit of variability across the state of Texas. There are places shown in dark green there where you had high vaccine interest and high vaccination rates. In contrast, in the light green, you have high search interest, but low vaccination rates. So maybe those light green areas are those areas where there's continued appetite for vaccines, but that for any number of reasons, there has been less success in vaccinating a significant enough portion of the population. I want to also call out attention to those white counties that you see there, which have a low vaccination rate right now and low search activity. And we suspect that the demographics of those counties are also quite different, and perhaps indicative of populations that, as a public health community, we haven't done a good enough job reaching and are not engaged fully in the discussion. So next slide. So as Tomer says, we also have the data at the zip code level. So here you see an analogous analysis, but now for Dallas-Fort Worth as just one example city, metropolitan area. And again, in the top left, you see the search activity in tertiles. And in the top right, you see the vaccination rate in tertiles. And when you look at the intersection of these two in panel C there, you see that again, a large metro area like Dallas-Fort Worth, it's not homogeneous, right? So there's places where we have low vaccination rates, but seemingly high interest based on the search index shown in light green there. And those, again, might be communities that might be particularly receptive to new vaccination efforts. I think that's my last slide, so I'll stop there and turn it back over to Ashley.
Thank you so much, everyone, for those great presentations and overviews. So to all of our participants here, feel free to continue to add questions into the Q&A feature. Before I open it up to all of you, and as we go through these questions, I have a couple of questions to kick us off that were based on those that we received in advance through the RSVP tool. So continue to add them. We'll start a conversation, and then we'll go back to those questions in the chat. So first, for Dr. Weintraub and Dr. Smith, understanding that access is really just one part of the picture, would love to hear what other additional efforts, gaps, and/or opportunities to help address the spectrum of vaccine confidence there are, particularly among communities of color.
So I'll give it a shot, Rebecca, and then hand it over to you. I think, as I alluded to in the opening, there are an entire playbook filled with the types of interventions you can try. But I think one of the most important is actually having an understanding of the community that you want to have increased rates. So it's great to know that people are interested, and it's excellent to know that you have means to increase the ease of access. But really understanding what's going on with people in that community requires partnering with people from the community, usually, so who have a deep knowledge. And then what follows from that is finding the trusted messengers. And each community is a little bit different. And this is especially true in communities of color. For example, in African American communities, historically over time, we found that religious leaders can be a really potent message deliverer. And so working carefully with these trusted messengers to ensure that their concerns are met, but also that they have the information that they need to communicate with the folks who listen to them is really important. And then, of course, as Rebecca alluded to, primary care physicians are pretty much universally respected. So, Rebecca, anything you want to add, please do.
Thank you so much. Just to augment, in many ways, when we see how the rollout has proceeded, as the supply got distributed locally to many communities, actually the uptake and the disparities changed. And so, we continue to see that it's individuals are willing to wait online to see their local provider or wait at a local center, a place where they maybe actually voted, for example, or went to a community event, for example, versus travel to a site. And I think this is actually typical of other public services, and people would prefer to receive the vaccine, just as Dr. Smith mentioned, by a provider that they trust and a location that is known to them. We also found that people actually appreciate waiting online. There's something about waiting on queue with your neighbors that increase confidence and people returning for the second dose to the same site.
Great. Thanks very much, both. So continuing with some of the questions that we received in advance, would love to turn it over to Mancy and Tomer to hear if there are additional data sets, sources, or partnerships that would be helpful to support and supplement these tools to increase usefulness. And particularly, there are a couple questions about plans for evolution of these tools going forward.
Hi. Yes, so I think, as I mentioned in the talk, I think those data that really augment other data sources like vaccination rates, potentially cases, and others, and kind of just being another insight or independent insights to those questions, because it's a very hard question of how do you get vaccination outbreak to be higher. We are partnering and we are talking to researchers, another organization, to kind of maybe build case studies around the data, and just like the work we're doing with Boston University about really understanding the data, to inform decisions based on it. It's not a trivial data set to use. Like sometimes, it's clear people are searching. How does that indicate real world events? All those questions are really good questions we're trying to explore right now to help use it. When it comes to kind of future plans, as I mentioned, we are looking to provide more insights to what are people actually searching, what are kind of key or top questions or queries they have, to bring more light behind it, understand how things change over time. So even if a number changes of how many, what's the the number of searches around one of those categories, the underlying questions actually change over time as well. That consist of that category. So that's another area that we are looking to address. Mancy, anything on your side to add?
Yeah, sure. So on the vaccine access data set, one thing that we are potentially looking into doing, and that could really help, is right now what we do is we show what the catchment areas of vaccine locations are and how the deserts, where the deserts are. Also looking at it from a census tract perspective, and looking at how, which census tracts have short access to vaccine locations versus those that don't, just a different view of looking at where these deserts are. That might be something that might be quite helpful, especially as you think about integrating it with other data like the vaccine search insights data that we talked about today. That's one potential area. And as we think broadly, even beyond COVID, the understanding access has such huge potential just beyond COVID and any sort of community resources, health resources. That's something that we are very interested in and looking at as we expand this data set. So those are some broad things on our minds. Back to you, Ashley.
Great, thanks both. And then we had a question as well, and then we'll turn it over to the chat ones after this. But for Dr. Wallenius, really curious to hear, based on the early results you presented, how public health officials can use this data in reality. And I know you covered this a little bit, but if you have additional points to add there, it would be great to hear.
Yeah, thank you. I think the key issue there is to use this type of data to supplement or complement local knowledge. Obviously, none of these analyses can replace the value of local knowledge in what works in any given community. And so, we are actively looking for opportunities to have discussion with potential collaborators on the ground that think that these kind of analyses might help inform their decisions, and we'd be happy to partner with people that are interested in doing that to really inform public health on the ground, again, as a complement to existing activities.
Thank you. And one note there, I know I mentioned earlier that we'll be sending an event recap afterwards with a link to the recorded session. We'll also have an email address, which if you'd like to connect with any of the folks that have spoken today, look for opportunities for partnership, collaboration, have ideas, you can communicate through that afterwards as well. So moving over to the chat, and the other thing as well, if folks want to ask live questions, there's a little hand raise function at the bottom. So feel free to just press that, and then we'd welcome your live questions as well. But as we wait for those, we've had a number of questions on the Vaccine Search Insights tool. Tomer, would you like to talk a little bit about, we had a couple questions related to how search interest is computed and what exactly it looks like as far as search content, whether the tool can allow the user to look at other search content. Would love to hear your thoughts there.
Yeah, so I'll go one by one there. So first, regarding the search interest, how it's computed. Yes, so as I mentioned, each category is the relative popularity of the topic. So we count the searches, let's say in a given region, a given state or county or zip code. We count all the searches that has to do with that category. Let's say it's a safety and side effects. And then we divide it by all search in that region. So what you get is a relative popularity of that specific topic across overall search in that area. So that's what we do in every region. That allow each region to be that value to be compared between regions over time. So that's how we compute search interest. We do also scale it by multiplying by some number, just to move from percentages to numbers that are more easily digestible, like between 0 to 200 or something. Regarding the second question from Helen, I think, as I mentioned, we are planning to add more information about what people are searching, or that's at least the goal. We are working on it right now. So I don't know if it will be keywords, but maybe trending topics, or maybe top topics right now in every region, or most region, I would say, in order to kind of provide more context and understanding what's being asked. And I see a question from Ali regarding, we don't have information about how often the researches are being done on behalf of the family, whether it's younger people or maybe adults that have not adopted as much Google search or the internet. So we don't know that, but we know that it is happening. A lot of people search for the dependents for it, but we don't have a way to quantify exactly how much that's the case. And Rohit, the data is not available through an API. It is available as the available data set. You can download it. It's updated every week. You can always download the file or have a script that does that and get the latest information from there. So it's just not an API, but it's available in a data form in the CSV format. That's with the specific ones regarding, I think, the vaccination search insights.
Thanks, Tomer. And if others, we hope that those answered your questions. If it didn't, or you'd like to ask a clarifying question, feel free to raise your hand or put it in the chat. We had a number of questions as well on the access tools. So I'm going to turn it over to that team. A couple related to the first, how do we know whether a health center is not distributing the vaccine? And then a question about partnerships as well, and whether we're partnering with a couple of folks that were listed here, including Hopkins, ComNovax team, Convince, or CUNY.
Rebecca, I can perhaps start on the not distributing the vaccine, and please feel free to chime in. And then I also see a question from Prashant that we can take. So in terms of like whether health centers are, for which centers are not distributing the vaccine, we do source the vaccine locations from a number of authoritative sources. For example, Vaccine Finder, and Rebecca, you may be able to add more there. CDC does require all vaccine locations or providers to report through the vaccines.gov website about when they're administering vaccines or their supply of vaccines. And so that is a really reliable source for us to understand which locations are distributing vaccines or not. In addition, Google gets sources locations directly from governments, from retailers, providers. And then we do also do regular evaluations on our data to understand how accurate our data is. So we have a fairly good understanding of where vaccines are not being distributed. But of course, if there are gaps that you find, please definitely reach out to the website, to the email address that's available on our data set. We'd be very happy to kind of collect that inputs and correct the data. I don't know, Rebecca, if you want to add anything to that?
Thank you. No, excellent. Eager for folks' inputs if they have other data sources that they'd like to see displayed on the site. We've had actually many of the state planners that we work directly with, especially in the South, have been very appreciative. They kind of utilize the download of the list to double check their current outreach to sites. So think of it to augment the current state and local planning. And Prashant, thank you so much for your question. I will take that offline, and that's an excellent idea. We'll probably have to circle back as a team to start working on that, and we'll reach out.
And there was also a question about, from a really great question from Alexandra on whether we're working with Hopkins Comnivax team or the CUNY team. I am not aware right now that we are, and we would love to, if you can connect us with them, we would love to connect with the teams and discuss both our access and search insights work with them.
Fantastic. Thank you, everyone. I think that covers the questions that have been in the chat. If we didn't cover any of them, please write it in or raise your hand, or we'll just open it up now to live questions or other questions in the chat. Thanks, Alexandra. Feel free to.
I feel bad asking another question, but really appreciated the presentation. And hi, Rebecca. I have like 14,000 other thoughts and ideas and folks I'd love to connect you to. I was curious, and this may be a little bit, this may be an ignorant question, so just bear with me, but we're seeing a lot in our vaccine equity cooperative work that Health is doing with National Association of Community Health Workers, Native Ways, and a few others. A lot of bright spots kind of organically pop up. So the one in Yuma, I don't know if you all heard about that, where public health worked with local promotorists, local CBOs, the Mexican consult, and actually worked across the state lines in California to have migrant workers vaccinated. What I've seen from a lot of the bright spots is exactly the kind of data you're tracking. So I don't know, can you back into bright spots if you have the data and kind of look at the delta of before the intervention was done and then post-intervention? Is that possible? Because I think that could be also powerful, especially as we've heard more and more that localities are looking for more bright spots, and it would be great to show geographically and through the data that you have how effective they've been.
Can you share just a bit on bright spot? I'm just not familiar with the effort. Just a bit. What do you mean by bright spot being what people are interested in?
So the intervention that was designed in Yuma was done by the Department of Public Health, by local promotorists, and they said, we're going to try to get 100% of migrant workers living here vaccinated. And so they ran the program with a lot of success, but I don't know that they can pinpoint in terms of both the geography, like the exact geography, or how many people were vaccinated. And I'm wondering if you actually could go back, if you had the right data sets, obviously, and kind of show, as you did with one of the other campaigns that you presented on, and show how effective that bright spot was. Because I think in spreading bright spots, you want to be able to talk about the actual number of people vaccinated too. And right now there's a lot of qualitative data, but I don't know how much quantitative data, and I don't know. It'd be really interesting, particularly the one that went across state lines, because they actually worked with Salinas, California to get people their second shot if they were going to work in California. Be really interesting to track that too. So I don't know if you're able to do the backwards looking, and if it's been, I mean, and again, it's dependent on the data, but is that possible? And if yes, like let's talk more.
Yeah, I would say our data goes back to start of 2021, so all the way from January, where you can download or look at the data in Dashboard Explorer. So yeah, in theory, it should. If there's an impact on search in those areas, it might be depending on the specific program and how they've done it. We should be able to see it.
And probably becomes harder with undocumented or folks who are living in multiple geographies, right? Like there's probably some limitations there.
Yeah, there's definitely limitations to the vaccination data, and that's where sometimes local partnerships might work. So like, you know, the data that's publicly available. So for example, not every state shares zip code level vaccination rate data, or those data are available today, but not over time in an archived way. So so we're able to do some of the type of analyses I showed you really nicely in a few states, but then there's many other states where we don't have that level of data. So sort of the finer, the more targeted the intervention is, the harder it is to find the data to assess its effectiveness in a way, or at least from these sources. Whereas when we have the state lotteries or the state, vaccination incentive programs, those apply to a large population where, if they have even a small effect, we should be, like Tomer showed a couple examples where you should see it. And then, really interesting question is how much does that interest in the program, which is reflected in interest in search activity, translates to additional vaccinations, and in who or where. So that's, I think sometimes these large scale questions are easier or more amenable to this type of data than sometimes the very targeted programs are hard, just because of, again, the privacy guarantees in the analytic data sets limit to how fine a resolution we can go.
Thank you. Thank you for letting me ask two questions too.
Thanks so much, Alexandra. Greg, it looks like there's another question or comment for you in the chat. I don't know if you've had a chance to take a look at that from Rohit.
Yeah, no, it's a great question. And so, if we weren't aggregating the data, if you could do sort of more of a nuanced, and Tomer discussed about how, the Google team, it sounds like from what you just said, Tomer, you're exploring sort of some more in-depth question, aggregating some more in-depth sort of topic areas. And, that's interesting, but it shifts over time. If you think of sort of the, searches for COVID and vaccine and infertility, that was peaked at some moment and is less of a prominent question now, at least in my understanding. And so the question is, like, I think different tools would answer different questions. So if you want to know, like, what is my community here worried about today, then looking in more depth at sort of the specific search terms would be really interesting, because then you could say, hey, we need to counter this misinformation, rather than trying to counter misinformation broadly. You could say we're trying to counter a very specific, 2 or 3 pieces of misinformation. And I think, I imagine that would be really helpful in a locally focused way. Again, sort of for some of the large scale questions, we took the overall VSI index, because we thought, even if you're searching for things that, like, side effects, or how long will I be out of work for while I get vaccinated, that still indicates an interest in the vaccine. So I think different parts of this index will just answer different questions.
Thanks so much, and thanks everyone for the great questions. If there are additional ones, please continue to add them in, or also feel free to ask them live. Otherwise, I see that we're just about at time. So as we mentioned before, really, first of all, really thank you to all of our presenters and to all of you for joining and engaging and for these great questions and discussion. This has been really helpful for all of us involved. And we really do look forward to collaborating. So as we mentioned earlier, we'll send out this recap email with some resources as well, and also our contact information. So would love to continue the dialogue, continue the conversation. If there's certain things that we could do more of or that would be helpful for public health, public policy decision-making, would love to engage in that conversation as well. And just want to thank everyone. Please be well, and looking forward to staying in touch.